All right, let's dive right in. Today, we're going to completely reframe how we think about one of the most common, yet honestly, most misunderstood conditions out there, osteoarthritis. For literally decades, the narrative has just been that it's a simple wear and tear disease. But, as you're about to see in this explainer, the actual science tells a totally different, incredibly fascinating story. We're going to explore the joint not just as some simple mechanical hinge, but as a dynamic, deeply interconnected ecosystem.
So I want to immediately shatter that old wear and tear myth right out of the gate. Osteoarthritis is not just about aging cartilage passively wearing away. What it actually is comprehensive joint failure. Literally every single structure within the joint undergoes a pathologic change. Now yes, it often kicks off with a focal loss of hyaline articular cartilage, but you've got to understand that's just the very first domino falling. We really have to view the joint as an ecosystem, because when one component fails, it triggers this massive, systemic whole joint collapse.
Here's our roadmap for today's explainer. We'll start by redefining OA as active joint failure, then dive into the chondrocyte cellular battlefield and map out the pathology of the joint structures. After that, we'll weigh risk factors like vulnerability versus loading, uncover the true sources of pain, and finally wrap up with targeted clinical management. Starting things off with Part 1, redefining osteoarthritis as joint failure.
The absolutely crucial point here is that OA is not passive aging. It is an active failure of the joint. To really get why it fails, we first have to understand what it looks like when it's healthy. Healthy cartilage relies on this genuinely brilliant biochemical design. It's built with type 2 collagen, which is tightly woven to give it incredible tensile strength. This collagen mesh physically traps another molecule called aggrecan. Now, aggrecan is packed with these highly negatively charged glycosaminoglycans. And because those negative charges repel each other, they desperately want to push apart. But that strong collagen network violently restrains them. This constant outward pressure, this dynamic tension, that's exactly what gives your cartilage its amazing compressive stiffness and its bounce. In osteoarthritis, that delicate, beautiful equilibrium is completely disrupted.
Let's move into Part 2, the chondrocyte cellular battlefield. Welcome to the true cellular battlefield inside the joint. When you look closely at this ecosystem, you've got synovitis on the periphery, chondrocytes sitting right in the middle, and the bone underneath, all actively talking to each other. Mechanical stress and injury induce this process we call mechanoinflammation. Basically, the surrounding synovium releases inflammatory cytokines and alarmins. This triggers the chondrocytes, which are the cells actually living inside the cartilage, to totally change their behavior. Instead of maintaining their home, they get provoked into releasing catabolic, matrix-destroying enzymes. We're talking matrix metalloproteinases, specifically MMPs and ADAMTS5. On top of that, vascular endothelial growth factor, or VEGF, triggers blood vessels to literally invade the calcified cartilage from the bone below. It is an absolute active war zone.
So how exactly does this war play out? Well, first we see surface fibrillation, meaning the cartilage gets roughed up. The chondrocytes actually start dividing and clustering together, desperately trying to repair the damage. But unfortunately, their catabolic destructive activity totally outpaces their ability to rebuild. Then, step 2, we get this gradual depletion of that crucial aggrecan we talked about, driven by those enzymes. And finally, step 3, without the structural integrity of that matrix, the tightly woven type 2 collagen literally unfurls. The negative charges of whatever proteoglycans are left get exposed, they attract water, and the cartilage actually swells up. At that point, it completely loses its compressional stiffness and its ability to bounce back after you put weight on it.
That brings us to our third section, the pathology of joint structures.
Now, all those surrounding structures, they don't just sit there while the cartilage breaks down, they react aggressively, leading to whole joint collapse. The bone sitting right underneath the cartilage, the subchondral bone, experiences microtrauma from that altered loading. In response, bone-building osteoblasts and bone-resorbing osteoclasts go into overdrive, causing the bone plate to thicken and become sclerotic, sometimes even before the cartilage is fully worn away. Meanwhile, growth factors like BMP2 and TGF-beta trigger the formation of brand new bone at the very edges of the joint. We call these outgrowths osteophytes, or as you might know them, bone spurs. Add in macrophages migrating into the synovium to cause inflammation, plus the joint capsule itself stretching out and swelling up with fluid, you can really see why this is defined as total joint failure.
Moving right along to Section 4, risk factors, specifically vulnerability versus loading.
You can really break risk down into two main categories: systemic vulnerability versus joint loading. Think of it kind of like a seesaw. On one side, you have a highly vulnerable aging joint, maybe in an older female or someone with genetic variations in the GDF5 gene, which actually affects joint shape. A joint like that can fail under completely normal everyday stress because its protectors, like bridging muscles and sensory nerves, just aren't reacting as fast as they used to. Now, on the other side of the scale, a young, structurally healthy joint might only fail if it's subjected to extreme loading. This could be due to obesity, which multiplies the physical force across your knee by 3 to 6 times with every single step, or it could be from a severe anatomical malalignment, like a varus, bow-legged knee that just crushes the medial compartment, or a major injury like an ACL or meniscal tear. Usually, it's a toxic combination of both vulnerability and excessive load that finally pushes the joint over the edge.
Next up is Section 5, Uncovering Sources of Pain.
Okay, I want you to really think about this provocative question for a second. It is a biological fact that healthy articular cartilage is completely aneural, meaning it has absolutely zero nerve endings. None. So if osteoarthritis is famously defined by cartilage loss, why on earth does the disease hurt so much?
Well, the answer lies in how we actually look at the joint. When we look at a standard X-ray, we see structural damage. We can see the joint space narrowing because the cartilage is gone, and we can spot those bony osteophytes. But here's the kicker. X-rays correlate very poorly with a patient's actual pain severity. Now, switch over to an MRI, and that is where we find the true pain generators. MRIs reveal the soft tissues and the bone marrow. You start seeing these intense areas of signal deep in the bone. Those are bone marrow lesions. They represent actual edema, microcracks, and scarring inside the bone itself, all caused by that intense focal mechanical stress.
So, the huge takeaway here is that the pain is coming from outside the cartilage. It's coming from synovial inflammation, which highly sensitizes the surrounding nerves. It's coming from joint effusions, where extra fluid is physically stretching the joint capsule and firing off nociceptive pain fibers. It's coming from those painful microcracks in the bone marrow edema we just talked about. And in the later stages, it's even coming from blood vessels and nerve fibers physically invading the damaged cartilage from the bone down below. Basically, the pain isn't just a cartilage problem. It's the ultimate clinical manifestation of a whole joint ecosystem failure.
Which brings us to our final section, targeted clinical management.
Because we now know that OA is driven by mechanical load and joint vulnerability, our treatments absolutely have to target those exact mechanisms. First off, weight loss is a massive force multiplier. Remember, losing just 1 single pound unloads multiple pounds of pressure off your knee and hip during a walking stride. That's huge. Interventions can range from diet changes to GLP-1R agonists all the way to bariatric surgery. We can also physically unload the joints using splints for the hands or by teaching a patient to hold a cane in the hand opposite the affected knee or hip. But honestly, perhaps most importantly, we have to prescribe targeted exercise. I know, it sounds totally counterintuitive to tell a patient with severe joint pain to go exercise. But strengthening those bridging quadriceps muscles is incredibly vital for restoring the joint's protective shock-absorbing ecosystem and boosting overall aerobic capacity.
We've completely shattered the wear and tear myth today. We've zoomed in on the cellular battles, we've looked at the structural collapse, and we've uncovered the true sources of the pain. So, knowing now that osteoarthritis is a dynamic, active ecosystem failure driven by vulnerability and load, I want to leave you with this. How will you take this deep mechanical understanding and apply it to proactively protect your own joint health or the health of your patients starting today? Thank you so much for joining me for this explainer, and I will catch you on the next one.